might as well get started. I hope everyone online can hear. If the microphone's very low here, so if you can't hear Kaiwen during this presentation, just make a note in the chat and we'll adjust our audio. Thanks everyone for joining us today for this month's edition of What's New in Addiction Medicine. My name is Paxton Buck. I am the program director for our Addiction Medicine Fellowship, and I'm very happy today to introduce Dr. Kaiwen Song for a nice, light, and non-controversial topic.
Not at all.
So Dr. Song is a fifth-year psychiatry resident here at UBC, who is doing his clinical addiction medicine fellowship with us concurrently with his psychiatry residency. When he is not confused by the many different opinions about safer supply, he has heard through a residency, he enjoys Lego, naps, and sugar, regulated supplies of Lego, naps, and sugar.
Yes.
He's going to talk to us today about a subject that I think is remains really topical for us, especially here in BC, but even elsewhere, and one that is near and dear to me, largely because of the amount of opinions and often the different takes that are circling. So Dr. Song is going to give us an analysis of prescribed hydromorphone and a summary of some of the data around the hydromorphone prescribing in BC, as well as an exploration of the alternatives. I will return at the end to help moderate questions. So again, for those of you joining online, just type your questions into the chat and we'll try and get to them by the end of the talk. I will turn it over to you, Kaiwen.
Thank you so much, Paxton, for the introduction. As many of you may know, my name is Kaiwen. Thank you all for coming. We're here to talk about a mildly controversial subject at times, and so I'm hoping to go through all of the evidence, some of my own thoughts. I'm happy to hear all of your thoughts, and I just want to acknowledge that although this is a very heated topic, I know that for everyone that I have discussed this with, ultimately at the end of the day, all we want is to really help our patients and do what's best for them and to keep them safe. And so, yeah, welcome to my presentation. First of all, let's start off with a land acknowledgement. I want to respectfully acknowledge that I am a humble guest on the unceded homelands and territories of the Musqueam, Squamish, and Tsleil-Waututh nations. Here is a table of contents of what we will go through today. We will do a brief kind of background about how did we actually get here. Then we will go over what actually is safer supply and its various definitions. And then look into kind of what happened after its implementation here in Canada. We will look at some quantitative studies. We will look at some qualitative studies. Shout out to my social worker colleagues as part of the program that have really broadened my horizons to qualitative studies, as well as some studies about prescriber perspectives, kind of hear us doing the work, what our perspectives are, and then go into some of the concerns and the controversies that have arisen as safer supply has been provided. And then what I wonder about doing next in terms of further improving the process for prescribers, for our patients, and for kind of our long-term longevity of these programs and what they can do to help. And if you have questions at any time, please just let me know. I'm happy to field them. And so let's start off with how did we actually get here? And so I don't think it's a surprise to us that there's been a significant increase in opioid overdose deaths over the past decade and beyond. And so it's one of BC's major public health emergencies. And so you can see that, here in 2023, in Canada overall, it's about 20 deaths per 100,000 people. And so while it's a little bit lower than some of our international counterparts, it's actually 3 times higher than the 2016 rate. And so over the course of 7 years, it's risen by 3 times in Canada in general. And then you look at BC in particular, where it's 46 per 100,000 people. And so it's 6 times higher than what it was back in 2016 for us. And as you can see, is 2.5 times higher than Canada overall. And then we take a look further at the downtown east side, where it's just extraordinary, over 556 people per 100,000 people, to really let us know that here in BC, especially downtown east side, it's a major cause of deaths. And the downtown east side is now 12 times higher than BC's provincial rate and is 27 times higher than the Canadian national average. So knowing that it is a major issue in our province, in our backyards. And tied into all of this is actually something that I thought we don't talk about often, is kind of our organized crime emergency, where we have a lot of non-prescribed substance use. Organized crime follows as an opportunity. And so there's reports by Peter German's report Dirty Money, where they reviewed kind of an independent review of money laundering in Vancouver and found that it's one of the most lucrative crimes, in Vancouver today. And in November 2018, kind of before the problem worsened further, Global News reported how organized crime groups have already laundered over $5 billion into BC's real estate, contributing to kind of our overall problem here in our province. And then because of that, what research has shown is that there are clear links between high level kind of gang involvement, the non-prescribed drug trade, and then how that leads to kind of higher levels of violence overall that we can see within our city. And there's and systematic reviews of studies examining associations between law enforcement and drug market violence found that as we increase drug law expenditures, as we try to contain the problem, we actually result in increased drug-related violence as the drug trade and the gang members fight back. And so it kind of contributes to this overall problem overall. And so it also leads to kind of this reputation for Vancouver worldwide. This is an article that was published in the UK about how, it gets very heated. They talk about decriminalization and about how Vancouver is now the fentanyl capital of the world. And so research will show that it's not necessarily actually true per se, although, the fentanyl issue in Canada has now become one where we were importing fentanyl to become one of domestic production and exportation. And so this change gradually began in 2019, where the Chinese government listed fentanyl as a controlled substance and imposed more regulations on its production and export. And because there's such high demand here, the organized crime situation here responded, and it's now a place where we produce and export our own fentanyl. And so, and there's now an alarming drop in the price of fentanyl, as much as 30% in BC, leading us to believe that there's now kind of more supply than before. And of course, there's then further reports that countries around the world are starting to receive fentanyl that they have been imported from Canada. So in Australia in 2022, it's estimated that they seized kind of 11 kilos of fentanyl. And in 2021, US has seized around 25 kilos. Still a very small percentage compared to what they have seized from Mexico, but it kind of contributes to our overall kind of global narrative as one of the main producers of fentanyl overall. And of course, all of these problems were further exacerbated by the COVID-19 pandemic, where in an attempt to protect patients who are extraordinarily vulnerable during COVID-19, especially the initial explosion area, when we're trying to get people to isolate in place to stop the spread and to protect them and others, there's a rapid expansion of safer supply programs within Canada. And so in BC, there was the prescribed safer supply policy as part of the risk mitigation guidance. And it's not necessarily always the best to be under a time pressure when you're producing a policy like this. And so, there may be unintended consequences of these policies, as we will look at during this presentation, although at the time it was very much needed in order to respond to kind of our dual public health crises, in order to try to keep as many people safe as possible. And so now we will delve into a topic about what actually is safer supply. It's certainly a question that has confused me throughout residency, and so I'm hoping to gather some more perspectives today. So it was initially introduced as a way of harm reduction. So it is not meant as a treatment in and of itself for opioid use disorder, much as in the same way that opioid agonist therapies like methadone are. And so its goals are ultimately very different. Its goals are to hopefully reduce the consumption of unregulated opioids, which are, and then in that case, reduce complications from exposure to substances that are contaminated in the non-prescribed opioids, and hopefully then reduce overall deaths by having people know that what is actually in the substances that they're using, so that hopefully they can use that to guide what they are able to tolerate and what they are not able to tolerate, and hopefully use it, as a safer way of using substances until they are ready to explore other options. And so, although there's been many similar models, the term safer opioid supply was first used to describe a program implemented in London, Ontario back in 2016, when they provided daily dispensed immediate release hydromorphone tablets for take-home unwitnessed use. And so since then, there's been various forms of safer supply. I think through our clinical work, the most common one that we're exposed to is the hydromorphone tablets. They come in 8 milligrams. And they're usually dispensed daily from the pharmacies. But there's many other forms as well. So there's people who prefer oxycodone. There's people who prefer fentanyl. And those other forms are becoming more common as well. And there's a lot of inconsistencies in the definition of safer supply that, I wondered about as well. So one of the terms that, I had to wrap my head around was injectable OAT. On the one hand is opioid agonist therapy, which I kind of associate with long-term therapy that stabilize people. But on the other hand, injectable OAT is actually IV diacetylmorphine or heroin or IV hydromorphone. But you rarely hear people consider PO hydromorphone to be opioid agonist therapy. So what was the difference there? And so, in speaking to different people, it really comes down to personal distinctions based on the following qualities. Do you draw the line at, is this something that is long acting, something that lasts around 24 hours, that will hopefully stabilize them in that sense, or short acting, where we think it's more kind of safer supply? So long acting then could be something like a fentanyl patch, where it's fentanyl, a short acting molecule, but it's provided in a long acting form. Or do we kind of draw the distinction as at whether it's witnessed or unwitnessed? The IV DAM, the IV hydromorphone, is always in a witness monitored setting. In which case, is that where we draw the line? Or do we have that transition as we continue to explore and receive evidence about its long-term stability? And so there is considerable evidence that injectable OAT, IV DAM, IV hydromorphone, can stabilize people over time on their opioid use disorders. In which case, is that where we draw the line? So I think I leave that up to you to kind of make your own personal distinctions, but it's important to keep in mind that when we talk about safer supply, there can be a lot of different definitions. And I just wanted to kind of share some personal experience with safer supply as well. I started my residency in 2020. COVID-19 was at its peak. Hydromorphone safer supply was just being introduced. And then when I started my addictions fellowship in 2024, some addiction clinics have actually stopped prescribing hydromorphone safer supply altogether. So just to show that in 5 years, a lot can change. And from what I've been exposed to, opinions about this are very strong and very diverse. But like I said, I think everyone has the same good intentions at heart. So let's go into some evidence about, so let's go into some evidence about what actually happened after, in the studies that look into what happened after we started prescribing safer supply more and more. And so luckily, a lot of the work has already been done for me through this very nice scoping review that was done in March of 2024. So I'll be going over some of the evidence from this and supplementing it with others. So I encourage you to go over this just to get further details about kind of what the lay of the land is in terms of all the evidence. And so I wanted to start off with some quantitative studies. And so there's 5 peer-reviewed studies in that scoping review, as well as 6 gray literature publications. And I think one of the first things that they looked at, and is something that we're all concerned about, is the risk of overdose from our safer supply prescribing. And so overall, there were 8 publications that looked at this, and they were all in consensus in reporting that there's no fatal toxicities and low occurrence of non-fatal toxicities amongst the safer supply patients. And that's across all 8 studies conducted between 2021 to 2023. And so, and then the London's, a study conducted out of London, Ontario, was the only program that followed patients long-term. So they follow patients over the course of 1 year. And still, there's no significant change in the rate of hospital-treated fatal opioid toxicity events compared to the people that did not receive the safer supply, which really aligned with the studies that evaluated kind of the more temporary emergency safer supply prescribing that occurred in the middle of COVID-19, where people were isolated for their 14 days of isolation in what was called these COVID hotels, where they were prescribed these safer supplies. And they also did not find any increases of fatal overdoses. And then something that I know our ID colleagues in the room may be very interested in is that they also looked at the rates of infectious complications with safer opioid supply. And what they have found that, so again, through that London, Ontario study, what they have found is that people that received opioid safer supply had less infections, whether it's osteomyelitis, whether it's endocarditis. They had less infections compared to the people that did not receive safer supply. So whether it is because they are, injecting a safer, injecting opioids that are not contaminated with other substances, or whether it's because somehow as part of this program, they are now exposed to more healthcare providers that give them access to clean needles and other harm reduction techniques, it's hard to tell, but this is kind of the overall findings that they had. And then something that we're always interested in, especially as we try to advocate for further programs like this, is what happens in terms of healthcare utilization and healthcare spending. So further on through that London, Ontario study, what they have found is that there's significant reductions in the rate of emergency department visits and hospital admissions for that 1 year follow-up for the people that have received safer supply compared to the people who didn't. However, there's no significant change in the rates of mental health related hospitalizations. So it seems like safer supply is able to kind of help reduce the rate overall, but not for mental health related hospitalizations. But that's just one aspect of healthcare utilization. What about healthcare costs in general? So what they have found is that if we don't look at primary care and we don't look at medications, there's a significant decrease in overall healthcare costs, where it goes from 15,000 to 7,000. However, this is followed by then an increased medication cost for kind of more outpatient care, where it actually increased from $12,000 to $21,000. And before people, become alarmed about how most of that cost is related to hydromorphone or opioid agonist therapy, that actually only accounts for 15% of that increase. And so what this suggests is that they are utilizing more outpatient services, more primary care services, and are maybe using more medications overall to maybe treat conditions that they would have not necessarily got assessments for, diagnoses for, and treatments for. And so although it may be seen as an increased cost, it could ultimately be a net benefit to our patients. And I wonder how that compares to kind of the costs of people who do not have opioid use disorder, and whether this is just, the cost of what it takes to keep people healthy within our country. And I think something that further we always think about in addictions medicine and psychiatry is their kind of social circumstances. What can we do to optimize other aspects of their life? And the 3 gray literature studies that evaluated this found that through a community center in Toronto, they found that 27% of people reported improved housing. 81% found that they had more free time to do the things that they wanted. 88% found that they had a greater sense of safety, and 85% found an overall improvement in the quality of their life. They also described further improvements in their mental health, in their relationships with their family and friends, and their relationships with community members. They also found that people reported that because they were receiving safer supply, they also received access to a lot of other things, such as help with social work to receive basic income, which allowed them to utilize more transportation, purchase food, purchase clothing. But overall, housing still remains a significant need for many of these patients. And the other thing that I always wonder about is, the crime and police contact, is something that's faced by our patients a lot of the times. And what they have found is that, once again, through this London, Ontario study, that 37% of people found that they had decreased police contact in the past 6 months after they started receiving safer supply. And then 38% were were previously involved in criminal activities to obtain drugs that was then decreased to 24%. And so overall, there's a decrease in kind of interactions with the within criminal activities, and decreased interactions with the police overall in terms after receiving safer supply, which could also be looked at as a net benefit for our patients. And then we look at kind of the more, other benefits. People have found that they had increased personal autonomy in terms of when to use the substances, because usually safer supply is dispensed in a way where they can use, in their own time. It's not something that they have to go at certain times during the day to go to a pharmacy to have it witnessed. If they wanted to, they could save up the substances for future events. If they wanted to go on vacation, for example, or if they wanted to visit family. There's an increased sense of privacy in terms of how they were using it, and there's less stigma. And then there's an increased perception of safety due to less reliance on non-prescribed opioids if they were receiving prescribed opioids instead. And so those are kind of the summary of evidence from the quantitative studies. I also wanted to look at the qualitative studies that have gone into this work. And there's been 7 major peer-reviewed qualitative studies that looked at the outcomes from safer supply. And they were published between 2020 and 2023. And a major finding is that while many safer supply recipients continue to use the unregulated drug supply, at least their self-reported frequency of use decreased, resulting in a self-perceived decrease in their overall risk of opioid toxicity. I'm not sure what happened to that slide there. And what they have also found is that there's been more stability in their substance use patterns, where where the safer supply helped them avoid cycles of withdrawal and cravings, and therefore less high-risk use. And what they have found is that the major motivation for people joining these programs was to hopefully reduce their risk of opioid toxicities and overdoses. As expected, they were all found to have an increased self-perceived sense of health, because they got a lot of access to treatment for conditions such as HIV and hepatitis C that were then diagnosed and treated. Whereas if they never accessed healthcare systems in the first place in order to seek out safer supply, it may have delayed the diagnoses and treatments of these conditions. They have also found that interactions with the Safer Supply program, provided wraparound services that help them with many aspects of their care. And what people have found is that, what the Toronto study has found is that 85% of people reported feeling more connected in general to the overall healthcare system. And they found that they had improvements in their overall mental and physical health. They also found healthy weight gain, increased stamina, and just better self-care overall. They also reported increased interactions with the healthcare system in general, where they received less stigma. And so overall, there was a reduced perception of the utilization of healthcare utilization in terms of overnight stays in hospital and stays in hospital for opioid toxicities. And they found overall improved relationships with healthcare prescribers as they become more engaged in care. And of course, we're also interested in kind of these social aspects where a lot of people reported that because they were spending less money on substances, they were then spending more money on food and clothing, and they had improved ability to pay for their basic needs. Although they still found that housing ultimately remains something difficult for them to access. And similar to kind of the quantitative studies, the qualitative studies also show that they have perceived a perception of decreased involvement in criminal activities in order to obtain the substances that they are using to meet their needs. And something that I was always interested in is, I get a lot of exposure to prescriber perspectives, but I wonder kind of what studies are out there to kind of look into this. And what they have found is that, at least in a study back in 2022, they have found that, a survey across Canada have found that, an overwhelming majority, at least somewhat or strongly agreed that, safer supply helped to reduce opioid overdoses. And that 93% somewhat or strongly agreed that it reduced IV drug use. And so these are quantitative studies that were done. And similar qualitative studies were found where they found that from the prescriber perspective, involvement in safer opioid supply programs provided clients with greater stability, increased access to other aspects of healthcare that improved their overall quality of life. So those are kind of the prescriber opinions that we've found. And of course, I wanted to delve into kind of probably one of the major topics here, which is our concerns about safer supply. I think that a lot of people, especially through our work, have been exposed to a lot of concerns. Certainly through our media, there's been a lot of exposure to our concerns. So I wanted to discuss them, unpack them, and to kind of delve into them a little bit further, because I think there's a lot of nuance there in how we interpret the data that we have. And there's just frankly a lot of things that we don't know yet about the impact that we have. And so the concerns, and it's not all doom and gloom sometimes. So some of the concerns were actually about how we can improve access to safer supply for our patients. There's been a lot of challenges with access when it comes to safer supply. Many studies have shown that they have found the way that safer supply is currently prescribed to be a major barrier. There can be inconvenient dispensing times. You have to go to pharmacies that can dispense it. There can be inconvenient dispensing locations. We always try to find a pharmacy that is willing to prescribe it as close to where our patients live and work and play as much as possible, but that may not always be possible, especially when we move to more rural settings where these providers and these dispensing locations become more scarce. Furthermore, certain safer supply programs have program capacity, such as our IV diacetylmorphine programs, which may not meet the needs of the people that actually need them. Furthermore, while hospitalized, there's a lack of access to that because they are no longer able to go to their pharmacies, which is why we rely on AMCT colleagues to kind of meet their unmet needs while they're in hospital. And as they go through kind of the system, as they learn more about safer supply and as they ask about safer supply, they can have negative healthcare experiences with providers who oppose a prescription of safer supply, which then could end up being a negative experience for them in terms of the healthcare system that makes them less likely to access it in the future, even when they really need it, until conditions get much more severe. So those are some of the things that we are thinking about when it comes to how to improve our safer supply programs in the future. There's also a lot of talk about the inadequacy of the most common form of safer supply that we are prescribing. So the most common form right now that we are prescribing is hydromorphone tablets. And how much of that is actually able to meet the needs of our patients who are often using a non-prescribed fentanyl, which is a much more highly potent form of opioids. So what they have found is that there's a significant mismatch in that potency between the unregulated drug supply and kind of the regulated drug supply that we are prescribing them. And so that could potentially be a possible source of withdrawal symptoms and cravings that patients who utilize safer supply experience, which then potentially leads them to supplement that use with more unregulated supply, which then, is kind of against what ultimately we were trying to do with the safer supply in the first place. Furthermore, there's a lack of variety in the formulations that are provided. Most commonly right now in Vancouver and in BC, again, this depends on the location. The most common way that people utilize opioids in Vancouver right now is by smoking it. And if we are prescribing our safer supply as oral tablets, is that really in a form that's actually accessible to them? Would they not bother and decide to use, powder that they could smoke instead? And if we're providing things such as IV hydromorphone and IV diacetylmorphine kind of in that more liquid formulation that they can't use if they want to smoke it, would that lead to other forms of use? And then there's also challenges faced by providers. I think there's a lot of questions there in terms of, all of this happened very quickly in the midst of the COVID pandemic, where there's a perception of lack of clear guidelines about what exactly to prescribe, how much to actually prescribe, and what to actually do about, how to monitor and manage it over time. There's also a lot of moral distress about the unknown risks of safer supply. Are they doing more harm than they are doing good when the data was so unknown at that time? There's high rates of burnout that is associated with addictions work when we are meeting patients that are facing significant challenges in many ways of their life, aspects of their life. And there's this kind of perception of lack of support from regulatory colleges to help with this process. Some people have found that by having safer supply as a conversation, it can increase challenges in establishing kind of more meaningful relationships, where they found that there are more people who are accessing healthcare services, but they are only interested in safer supply. But then is that a conversation about, are these people that we may not have necessarily reached at all if we didn't have safer supply? It's unclear kind of what questions that this can lead to. And as certain clinics continue to prescribe safer supply and other clinics have stopped prescribing safer supply, and as there's different guidelines about when to start taper off of safer supply, it can lead to very challenging patient encounters that may or may not kind of be ultimately beneficial in terms of our patients' perception of the healthcare system. So it's certainly a challenge that we should be aware of and think about further. And of course, a very popular topic is diversion. It's more about, what is actually happening with the hydromorphone tablets that we are prescribing. And I think overall there is, what I have found, at least in our qualitative studies and in our gray literature studies, is that there is a consensus that it is being diverted. There is hydromorphone tablets that are being diverted as part of the program. And what they have found is that in an evaluation of 10 kind of safer opioid supply programs across Canada, they have found that in those locations where the prescriptions are taking place, there's a kind of increase in the availability of hydromorphone tablets on the, in the streets, associated with a decreased street value of the hydromorphone tablets. And that's certainly something that we have seen in Vancouver and BC as well. It's interesting because there's actually limited quantitative studies done by this. There's only one quantitative studies done by this where and it's actually during a COVID hotel stay for the 14 days where they found 3 out of the 27 people were diverting it. And that's the only quantitative studies that I was able to find. And so it's interesting to know that there's no actual quantitative studies about it and whether that's just an associated challenge with trying to measure diversion in a quantitative way that is reliable. But it's certainly a topic that is very, controversial. But there are a lot of studies that look at the reasons for diversion, which helps us unpack the nuances of the situation. And so some of the diversion has been reported to be more compassionate sharing with other people that were maybe not able to make it to a clinic to get a safer, to get a prescribed opioid supply. And it was to help them with their withdrawal symptoms. Other times, it was really to help supplement their unmet financial needs. They were selling the hydromorphone tablets in order to purchase more food or clothing, or because they found that the tablets were not able to meet their opioid needs, they were used to then purchase higher potency opioids, which I think identifies, certainly you can interpret this data in a very concerning way in the sense of it's not being used in the way that it's meant to be. But I think it also provides avenues that we can further improve the programs that we provide our patients so that we try to minimize these risks of diversion further. Furthermore, there's been qualitative studies showing that participants in the Ottawa Opioid Supply Safer Supply programs and in the London, Ontario Safer Supply programs say that diversion is not unexpected, in that any program such as this, whether it was methadone in the first place, always have an element of diversion, and that is actually to be expected as part of any of these programs. Furthermore, at least in the qualitative studies, the people that have diverted their safer supply have always said that they share their opioids with people who were not opioid naive, which is often a major concern, especially in our media, about diversion of opioids. And then there's also kind of that diversion from a provider perspective, because it leads to a lot of complex situations and conversations with our patients. For some people, for some prescribers, they found that having the urine drug screen being a part of the process kind of increased comfort, because if the urine drug screen showed hydromorphone, then they have some comfort in that at least not all of it is being diverted. However, we noticed kind of the potential harms that asking our patients to provide urinary drug screens in order to provide safer supply can actually cause our patients, in terms of whether they feel like this is a sense of judgment, whether they feel that this is a lack of trust, that could then color their perception of the healthcare system. And then it leads to a lot of challenging encounters with patients who are in fact diverting. What are the limitations for stopping your prescription of diversion? I know personally, it's been very challenging when meeting patients who say that they are diverting their opioids because they have unmet financial needs, and that by selling their non-prescribed opioids, they are then involved in other higher risk, more risky forms of crime in order to obtain those funds. It's a very interesting kind of moral questions that we have about how closely we want to adhere to the actual role of safer opioid supply and what we should do about it. And of course, we live in society, and we are always going to be, at the mercy of our current political climate and our public opinion. And I think that can certainly color our perception of what we are doing and color other people's perceptions of what we are doing. And so these are just some examples of headlines about, what is happening in Vancouver in terms of, war. They call it a war over safer drug supply in Vancouver. You have found, how does BC Safer Supply Program work, and is it being abused? There's lots of questions. And I just want to notice there's two families so there's, definitely, articles about two families that sue, province, the federal government over safer supply, and certainly not something that we want to see. But I want to highlight, these are two major articles that were actually written by the same person. So how much of that kind of noise out there is amplified by a few people with very powerful reach versus a general perception that's actually experienced by many people? And then, of course, there is what happened to our Drug User Liberation Front, where two advocates were actually charged with trafficking and are now facing criminal charges, which is certainly not something that I think as prescribers we want to, potentially even have the possibility of facing as we prescribe safer supply. But that is a little bit different because these were not actually medical prescribers. This was a different model that I will talk about further. But just to highlight that there's certainly very intense political debates in our country about, the direction of safer supply and whether it is ultimately more harmful than good. And it's something that we need to keep in mind for the future as we try to design safer supply programs that are going to be more sustainable over time. Because, like it or not, in order to have something sustainable and acceptable, we need to make sure that we are as aligned as possible to the political climate and that we are facing more public support than public opposition. Because public opposition can lead to political will that could potentially have negative consequences for our safer supply programs as we try to help the patients that we are seeing. And there's a lot of moral distress in terms of what we're doing in general. And I received many questions from people leading up to this talk about, are we enabling people? What if our patients overdose? What if people just come to me for quote unquote free drugs? These are all sorts of moral questions that we have to, reflect on for ourselves in terms of what is our goal of the safer supply and where we draw our own line in terms of what we are doing. And other people found that gatekeeping people's access to substances seemed not what they went to medical school for, not what they actually see as part of their role. And they see it as kind of more negative experiences with their patients that they ultimately think should not be part of the medical system in general. Not that they don't think it should be part of the system, just not part of the medical system. Which leads me to wonder, in looking at all of this data, what we should do next in terms of further improving the safer supply programs that we have within our country. And I think the first thing that we want to say that it's not a one-size-fits-all situation. And I think that's the challenge with, safer supply programs is that for the ease of, sameness and for the ease of providing, some guidance, that it's usually, what we see most commonly is kind of prescribed hydromorphone tablets. But the thing is, depending on the local context, are people using hydromorphone tablets or are they using fentanyl? Are they using tablets or are they injecting or are they smoking? Depending on that local context, we may need to adjust our safer supply programs differently in order to provide an actual equivalent to what they are using if our ultimate goal is for them to use less of the unprescribed opioids and more of the prescribed opioids that are not contaminated with other substances. And furthermore, an effective safer supply needs to have similar potency to the substances that they're meant to replace. So in an environment where we're using lots of fentanyl, does it make sense to have any safer supply programs that are utilizing hydromorphone? Versus in places where they do not have as much access to fentanyl, by the same coin, we should not be prescribing fentanyl as our safer supply. And furthermore, we need to prescribe them, as I mentioned before, in a form that more easily replaces how people are currently using them. So all of that is to show that there ultimately needs to actually be many different kinds of safer supply programs that really tailor to the local environment that is being provided in. And I just want to go over kind of one example of kind of this approach. So Dolph's Compassion Club is something that you may have heard of. So in 2022, the Drug Users Liberation Front's Compassion Club and Fulfillment Center, they were this new groundbreaking initiative in Vancouver where they, in order to try to prevent overdoses in the downtown east side, a group of people with lived and living experience came together to develop a nonprofit, low barrier, and more importantly, non-medicalized approach to accessing safer supply. They provided supervised consumption services if needed. They obtained rigorously tested cocaine, heroin, methamphetamines at and then provided it at cost to their users. They had a whole process in order to ensure that people who are receiving their services are not substance naive. And the ultimate benefit of this program is that there were no actual healthcare providers that were needed as a part of this process. There were no doctors that were needed in order to provide the prescriptions, which bypasses some of the concerns that prescribers had about it. And they also bypass kind of the most common distribution models about having to go to a pharmacy, having it be dispensed daily, where they go to somewhere else where it is dispensed, from a non-medical environment where they may feel more comfortable in, where they may have more access in. So that is one of the programs that was started back in 2022. And in terms of thinking about our concerns about safer supply and in general, we talk about kind of the access to the programs and whether it can be gatekept by the medical system. And in some ways, it is addressed in the sense that you no longer need a healthcare provider to prescribe you safer supply in order to access a regulated supply of substances. However, there were still limitations in this program in terms of their hours of operation. And so there's still that question of maybe it's no longer dispensed from a pharmacy, but it's still dispensed from somewhere that had limited hours. In terms of the adequacy of potency, I would argue that they actually address that by providing substances which at the time, substances in a way that is in a form that is used by our patients. And in terms of diversion, it's a complicated question. So certainly the substances were made available at base cost because they wanted it to be a nonprofit organization. And so they were provided at cost to its members. Base costs for these substances are not necessarily street value for these substances. And so it may have partially affected kind of diversion in terms of people are no longer receiving quote unquote free substances that can then be diverted. They're still spending some money on it, but are they then utilizing that and selling it at street value elsewhere? It's unclear. But I think the ultimate downfall for this program overall was that it was highly politically unacceptable in a very charged political environment. So much so that it led to severe consequences that I will talk more about later on. So first of all, some further recap of the benefits. There's no healthcare providers needed, and it may be something that's more easily set up in rural environments and other lower resource settings where you have limited pharmacies and limited prescribers. It's often said that in rural settings, losing an opioid prescriber, losing a safer supply prescriber can be very devastating to the patients in that local area because it can be very challenging to find someone else who is then willing to prescribe it. But then, of course, the major challenges of that is kind of the legality piece. And so after a year and 2 months of operation, they actually faced an abrupt raid by the Vancouver Police Department that resulted in the program being shut down. And at that time, there's kind of unintended consequences as well. It led to the seizure of all of the computer systems that they were using, all the localized data that they were using. So I'm not sure what kind of data they were collecting on their users, but it certainly then fell into unintended hands. All of the substances that they had, all of the equipments, were all taken. And then, of course, both founders of the program had their homes raided and have been charged with possession and intent to traffic, which each charge carrying a maximum sentence of life imprisonment. And there's quite significant consequences for the people involved that have tried to, from their perspective, bypass what they saw were limitations of the medical system in prescribing safer supply. Which leads me then to something that I heard about, only as part of the program this year that I wonder about. It's something called the Safer Enhanced Access Program. It's currently operated through the Columbia Street Clinic in the downtown east side. And they provide fentanyl powder at equivalent street value to its patients. I had the privilege of working there over the winter months and see this program in action where it's still a medical system in the sense that they meet with at least 2 different prescribers in order to determine their eligibility for the program. And then they meet with a pharmacist who is then, titrating them to make sure that they are able to tolerate the regulated fentanyl, because as we know, non-regulated fentanyl can be laced with all sorts of other substances, which makes it hard for us to actually gauge how much fentanyl is in the fentanyl that our patients are using. So there's that titration process. And then they are able to purchase it at street value from the clinic itself. So in some ways, it's a hybrid of both systems where there's still that medical system, but it then, it's no longer a prescription that is provided free of charge for the patients. So then in looking at it, there is that concern about, all of our concerns about safer supply. Is it addressing kind of access? I would argue that in many ways it does. In the downtown east side where Columbia Street Clinic is located, as we discussed, most patients utilize fentanyl by smoking it. So they actually formulate their fentanyl to be in a way that can be smoked, in which case it's directly replacing what patients are using. Is it adequate in terms of its potency? There's that titration process, but by prescribing fentanyl instead of hydromorphone, it is trying to meet patients in terms of their needs. Is it addressing kind of the diversion needs? I would argue that by prescribing it, by providing it at street value, that it is as much as possible meeting there, because now patients have the choice of using the same amount of money, usually $10 per point or 0.1 grams of fentanyl, and they can choose to either use that through the Safer Enhanced Access Program, or they can use that through their supplier on the streets. But it's the same amount of money that they're using for the same amount of fentanyl. And so are we then able to then really capture the population where they are ready to make that next step of using a regulated supply? Questions that need further research in order to fully answer. And then there's that political acceptability. So I had an interesting conversation with people who ran the program about just how much kind of political, regulatory oversight that they had in order to get this program approved. But because it is then approved by, our government and the regulatory bodies, it doesn't face the same kind of risk that the DELF Compassion Program faced. And so is this a way of making it so that it is more politically acceptable? And I think in some ways it removes kind of the low-hanging fruit that the criticizers of the programs have about providing quote-unquote substances at no charge to our patients. Sorry, I realize I'm really going over time here. But overall lessons, that I wonder about is safer supply needs to be in a form that actually meets patients' opioid needs. And so for our patient population that is largely using fentanyl, doesn't make sense to prescribe them with hydromorphone when we know that it would likely not meet their needs. It needs to be easily accessible in the forms of timeliness and location. So should we be gatekeeping it in clinics that do prescribe it and in pharmacies that do dispense it? To avoid diversion, should it be, at street value, or should it be at cost, or should it be free? And it needs to be adapted to the local context and the wider political environment. And also, further questions from this is, if we implement these kinds of changes, then do we actually lose some of the benefits that we had from kind of our current system where we are prescribing safer supply at no charge? Is it enticing for patients to visit a clinic in order to get it free of charge? And then we can meet them where they're at, provide motivational interviewing, provide wraparound services like access to social work that they may otherwise not have sought out if they said, oh, I have to pay for the safer supply. It's all very complicated questions that I think needs further research to address. And overall, that is my presentation. I have left only 4 minutes for questions, and I apologize.
Thank you, Kaiwen. Thanks. I'm just going to try and pull up the questions online. We have time for one or two from the audience. I think that the takeaway, I appreciate that whirlwind review of the evidence on a rapidly evolving subject. But your last point, they're just around the complexity and the nuance and the context's specific considerations. I think hopefully that's a takeaway message here. It's a complicated subject, and it's okay to have complicated feelings about it. Where's our questions running there?
Oh, probably.
There's none yet? Okay.
Oh.
Yeah, questions from there. Questions from the audience.
Oh, just a comment saying very excited for this talk. Thank you for coming.
All the way from Boston.
Oh, really?
Boston, yeah.
Oh, nice.
Any questions from the audience? Everyone's just digesting. Yeah.
Oh,
sure.
Go ahead.
I was wondering, the comments about the physician that are like moral dilemmas. I'm wondering, is it like, do we know the context in which these happened? Is it because they didn't feel supported, were trained up, or understood maybe the wider issues that or still had doubts on whether or is it people who have been in the space for a long time and then I'm just wondering what kind of
yeah, that's a great question. For those who are listening online, it's a question about for prescribers who have, moral distress and questions about it, where that could be coming from. Is it lack of training, lack of experience, or do they have a lot of experiencing and they're trying to share kind of what their, thoughts and expertise are? And I think that's a very complicated question. And I think that to a certain extent, I think all of us have some level of moral distress about the provision of safer supply. And I wonder whether a large part of it is we're not sure what the evidence is in terms of what it's doing for our patients. Are we ultimately helping them? Is it a net positive, or are we leading to unintended consequences that we weren't aware of? And I think initially, when this was first rolled out back in 2020, there's a lot of questions about that. And I wonder, as further evidence arrives one way or the other in terms of whether this is ultimately a benefit or not, I think that hopefully some of that moral distress will decrease. But I think a lot of that comes from our kind of, lifelong experiences with substances and our experiences with doing work in this very tough field and the patients that we see and the patient experiences that we have where we can either see it help certain patients, we can see it potentially harm other patients. And I think all of that will certainly inform our opinions about it. So I think it's a complex issue. And I actually think it's a healthy issue to have in the sense that there should always be some sort of questioning about what we're doing, reflection about what we are doing. And what I hope to encourage is for us to have further conversations about it so that we are not having moral distress alone and that we are having moral distress together.
And that was a very articulate answer, Kaiwen. The one other thing I'll add to that is for those who are interested in delving more into that, just to plug Kathleen Bird and Sarah Ekowitz, two of our AMCT staff here, just published an ethical analysis of safer supply prescribing and interviewed a dozen prescribers around their, the complex feelings that people have. And so it's a very thoughtful piece that I would encourage any of you who are interested to go read.
Thank you so much for your question.
Yeah.
Oh, for sure. Do we have time
Did
for
you want
one
one more question, Mark?
Yeah, it's probably more of a comment, but I guess I would think that a guaranteed non-contaminated fentanyl would have a higher street value once it leaves the clinic where it was purchased.
So that's yeah.
So how would one get that kind of evidence that there is no such diversion occurring?
So I think that's a question that I will need to delve further into, because my understanding is that it's not necessarily they're provided with 1 point of equivalent fentanyl, but that they are trying to match as much as possible kind of the formulation that's available from the streets and in matching it in terms of potency, but I'm not certain about that.
I mean,
Yeah.
you're right. It's trying to match. It's actually it's roughly equivalent or slightly more concentrated than. So it's as good or slightly better than what's on the street, and it is predictable. And perhaps it has, for some people, added value, but it's meant to be priced at a roughly equivalent. So the profit margin, if it's there, is not. Depending on who you're selling it to, is not enormous. But
if I can follow up, that's all about the fentanyl part. I guess if people are guaranteed that the fentanyl that they're buying in the clinic is guaranteed not to have any benzodiazepines or other sedative hypnotics, wouldn't that therefore lead to it having a higher street value?
Actually, I can speak to it really quick, Mark. I work in the clinic, and we actually find that people that are purchasing it from the local area find it not as effective because it doesn't have the things that they're used to buying opiates with, like benzodiazepines. So it's true that a lot of our patients come and talk to us about how helpful it is or isn't, and if it isn't, they're just going to have to buy it. It's not losing up prescriptions. We do get a lot of truthful conversation. No one's trying to hide it in their urine, like they're going to buy it or they're not. So people where it works, and often it works best when you off their benzos. And otherwise, it isn't as helpful in some circumstances, but for many it can be. So it's a good point. I mean, we certainly don't see that there's a lot of diversion happening because of us trying to meet the street value amount. But then there's an issue of people being able to purchase it, and how on the street dealers will give you a supply up front until you get your check. And so really also charging a certain population that has a bit of money.
Thank you for those insights. And to further address your question, Dr. McClain, I think, once it leaves the clinic, there is no guarantee then that it would be, not contaminated. So then whoever you're buying it from on the streets, they can say that they got it from the clinic, but how can you be sure? In which case then, how can people say that this is definitely not contaminated? Because I imagine there's certain, and again, this is all conjecture at this point. I imagine there's, probably, people on the streets who say that, mine's definitely not contaminated. And so it's hard to say. Back there.
Used to use drugs.
Yep.
I'm going to come up with this question. What is the regulation around somebody taking the supply that they're buying, cutting it, and then that way they're making more money and more supply, right?
Yeah. But then what I'm trying to then question counter to that is what's to them from buying the same amount on the streets, cutting it further, and then selling it further. So I think as much as possible, it is really trying to mitigate the risks associated with the non-prescribed ones as much as possible. But of course, there's always going to be further questions that need answering and pondering.
I think we're running over time. There's, I'm sure, many more questions. I'm sure Kaiwen will be having a chat after this. Thank you all for joining. We had a good crowd today, and we'll see you again hopefully next month.